Hello, everybody. Thank you for joining us for another episode of Pharmacy Pathways. Today we have with us Dr. Frank Tillman, and he is a clinical pharmacist who specializes in the field of mental health. So he is going to be talking to us about his journey, the training and background that he has, and what he does today on a daily basis. So without further ado, I introduce to you Dr. Frank Tillman.
Hello, everyone. How's it going? And thanks, Dom, for having me on your podcast.
Yes, I'm really excited for you to be here. I was class of 2020 at UNC, but you were class
Yeah,
of 2019. We had about 3 years in pharmacy school together, and your class was very instrumental and influential in how our class grew and developed, and we looked to you guys as mentors throughout the program. So it's really awesome to circle back and to see how you've been, what you've been up to. So with that being said, why don't you give us like an introduction as to who you are?
yeah, for sure. I'm pretty sure I'll be going into a little bit more depth throughout the talk today, but I'm a psychiatric pharmacist. So I work in an outpatient clinic, married to my wife now since 2017. Don't make me do the mental math. And then I've got two girls. So I'm a father, husband, a pharmacist. So that's me.
I wanted you to spend a little bit of time on talking about how you got into pharmacy school in the first place. Like what drew you into the profession? When were you first exposed to this as an option?
Yeah. So I kind of knew that pharmacy school was the route for me early on. I did a like summer enrichment program. It was like a STEM related program for marginalized, underrepresented minorities. And so we spent the summer at Duke and UNC and NC State. I was at Duke doing research. So it was a lot of benchtop research with graduate level research. I was in 10th grade, didn't know much of what I was doing, but just out there learning. And one of the components of the program is that they would bring in these different healthcare professionals. So they would bring in like nurses and nurse practitioners and CRNAs and physicians and dentists and veterinarians. And of course, they brought in pharmacists as well. And what really stood out to me, what struck me was I could just like feel the burnout from all of these other professions. And they just really, they weren't selling it, right? Like they just weren't selling it. And, that was the impression that a lot of us got at that time was just like, well, we definitely don't want to do that because they're talking about student loan debt and like getting no sleep and, all this other stuff. And then, fast forward to the pharmacists come in, they were there talking about like, I love my profession. It's exciting. I've got a lot of flexibility. Like I started in community and now I'm doing industry and then academia. So it was just like so much flexibility. And of course, as a 16-year-old kid, you don't want to sign up for something for the rest of your life and you don't have much wiggle room to pivot, right? And so that was really attractive to me. And then I think the thing that really got me, there was a faculty member at the UNC Eshelman School of Pharmacy at the time, who's still faculty now. She was kind of the person who spearheaded all of these pharmacists coming and speaking with us. And her name is Dean Carla White. Shout out to Dean White. You know Dean White. And she just had this very personable persona. She was like full of love. And I could really tell that like she wanted each of us to make it. It didn't have to be pharmacy, but she was just like, look, I want you to make it to that next step. And we just stayed connected throughout that time of like high school and then me matriculating into college. And she was just that like beacon of support. And I was just like, you know what? Like this is a sign. Like this is my thing.
Yeah.
And so I came into college and I was like, pharmacy is what it is. That's what I'm pursuing.
Yeah, it is so crazy how we present ourselves can really impact like people's decisions. If we go around looking miserable, nobody's wanna do what we do.
Right.
And it's also interesting because I wonder now if pharmacists came to that panel today, if they would still look refreshed or have a tad bit of burnout.
You catch me on the right day. I might have been one of those.
Yeah, me too. Me too. I think that's healthcare across the board though. We do need a change as a whole industry. But you are, as you stated, you are in mental health. That's a very specific field. And to a lot of folks, that can feel a little intimidating and complicated. So what led you to mental health? You're now in pharmacy school. How are you thinking about what you want to do when you graduate and where you want to go with this degree?
Yeah, yeah. So when I first came in pharmacy school, so my grandfather passed away from lung cancer, and so I just came into pharmacy school, and I was like, I'm gonna do something oncology related. And I wanted to also like I was like, well, maybe I'll do like pediatric oncology, right? That's just what I came into pharmacy school with. It sounded good, right? And I was just like, oh, I'll do pediatric oncology. And then I realized I didn't like oncology at all, right? Did not like it. And then I also, pharmacy school, like I didn't like pharmacy school at all. Did not like it. It just, it was rigorous and it was supposed to be rigorous, but it just wasn't jiving for me for a long time. And it wasn't until I started like the therapy modules and, I was doing like the psych modules and I was like, wow, like I like this. I like thinking in the mindset of receptor binding and, being able to be a little bit creative with like treatment plans based on like side effects and taking advantage of certain side effects to treat certain symptoms. And it felt like an art, but also a science at the same time. And so I was like, wow, I really like that. And then again, like another person who was impactful, it was the course director. The course director was someone who just kind of like stood out to me from compared to like maybe some of the other professors, and like he's really into like well being and seeing the student for who they are. And so I don't know if it was a combination of like I just really looked up to this professor, or and I'll shout her out too, Dr. Suzanne Harris, who has been a mentor, colleague, now a friend. But yeah, I don't know if it was just like I really look up to her and what she represents and how she's shown up for her patients and now her students, or if it was the combination of like this art and the science, or maybe it was both. But it was definitely like within the classroom setting where I was like, okay, I think I want to do psych. And then I started doing like clinical research with Dr. Harris, had like fourth year rotations, kind of grappled with some other specialty interests, but ultimately I just knew in my heart that it was psychiatry.
Yeah, because you were on when you say you grappled with other interests, you weren't looking for oncology, but you were thinking about cardiology. It was coming down to between cardiology and mental health. What sealed the deal? Like what tipped the scale towards mental health at the end of the day?
Yeah, yeah. So as you mentioned, so like the pediatric oncology, that was like far out, like yeah, like first semester done. Cardiology, it's so funny that it was between mental health psychiatry and cardiology for me, because on one end, cardiology is like it's very like there's a lot of like very specific data. You've got algorithms, you've got stepwise approaches. And in mental health, like you don't really have like the algorithms like that, right? You do have data that guides your decision making, but it's not, so prescriptive. In my opinion, a lot more gray in mental health than maybe what there is in cardiology, not to say that that doesn't exist. So there's like two like competing kind of pieces of my brain. Like, okay, like what do I do? And again, tapping into great mentors. My fourth year, I didn't have any. I didn't even have like a psych rotation initially. And then I talked with Dr. Harris, and she was like, "Oh no, we're gonna get you a psych rotation." So she, did some reaching out. I got one outside of kind of like the AHEC, the area that I was assigned to, and just like, I think things were just set up so nicely. God just set things up so nicely that I had the rotations back to back basically. So like I had my cardiology rotation first, and then the very next month I had psych, so I could like compare them directly together. And it was all the same things. Like the art and the science was just driving me more, but then also like the population, the people. I'm an equity driven type of person. I think through the lens of cultural competency. I think through the lens of how do I help marginalized folk get better, improve their outcomes. And it's not to say that you can't do that in other specialties, but mental health is definitely one of those areas where it just comes up every day, every patient interaction. And so it was just like, yeah, this is where Frank needs to be.
Yeah. And it was right on time because you had to apply for residency programs.
I did, yeah.
How much notice did you have before you were like, okay, I'm doing mental health and all right, now I got to find a residency. And how did you navigate that?
Yeah, it was like a 2 month turnaround. maybe a month. Yeah, it was like a month after I had my psych rotation, and I knew that I was going to be applying for residencies, but I just didn't know like what route I'd be taking, of course. And so it was just like rapid. Like I'm looking at all these programs, and there's so many programs, right? So how do you even like decipher it down? I ended up applying to way too many, as you know, way too many programs.
Now give us the number. Let them hear the number.
Yeah, I applied to 19. I applied to 19 programs. Yeah, 19 programs.
You had shmoney because them applications are expensive.
Credit cards maxed out. Yeah.
Oh my gosh. Why 19? Why 19? How did you narrow it down? What was your thought process like?
Yeah, I mean, honestly, I had such significant imposter syndrome. UNC is like it was the number one school of pharmacy. I think it still is the number one school of pharmacy. If I don't quote me, I think it is. And so of course you've got like all of these like brilliant, super smart classmates who are competitive, and so you're taking tests every week, every day in many cases with these people, and they're making hundreds, and I'm making not that. They've got folks. I don't have that, right?
Yeah.
And so I just kind of felt like there's no way that I'm going to be able to like match. Like it's not going to happen. It's what I convinced myself. And so obviously I was like, well, I just need to apply for more programs so that way hopefully I can get two interviews, right?
Two?
And so
Like you just wanted two interviews?
I just wanted two. I just
Oh,
wanted two. I just wanted two. And I ended up getting offers, interview offers for all 19, and I think I pared it down to like 17. And so that just was like a reminder, like, why are you being so hard on yourself? That theme has come up in my life so much with imposter syndrome and so forth. But yeah, like I essentially like yeah, I went to mid-year, I got to talk to the programs. This is of course like pre-COVID, so it was like I was face to face with the programs, got to fly out, drive to the interviews and get the feel. And over time, my confidence was building up, and so it was for me. The objective things were, is the program well rounded? Do they have inpatient, outpatient? Do they have a PGY2 psychiatry program? If they didn't have it, like I wasn't going to apply. I wasn't going to waste my time. And then the big thing in terms of rank was, all right, like how diverse is the programs? If they're not diverse, like do they consider inclusivity at all? Is
uh-huh.
there like can I feel the equity within it? Can I feel the cultural competence within it? Will I be will I be more than just a resident at this program? And that was kind of that's hard to measure. It's hard to get a good sense of.
Yeah.
And so I just was going with my intuition, going with my gut, going off the vibes,
Going off the vibes.
and did my rank list. Yeah,
That and that sounds funny going off vibes, but that is so important. Like when you're on that interview if if you're going to be okay there or not.
for sure.
If you're going to be valued, if you're going to be treated a little funny, you definitely can feel those vibes. And I felt the vibes, but I ignored them because, that's just what I did at the time and it was unwise. I matched with where I actually had the best vibe with though, because God knew. He was like, you know what? She playing.
Yeah, I
She's
be
really
knowing.
playing. Yeah, he knows, he knows. But the place that I felt the most warmth, just across the board, like I would fit in here. I like what they're doing here. That's where I ended up matching. And I'm so grateful for that. But so 19 interviews were offered, and you hoping that you could get two, you actually turned two down, went on 17, and you said that you knew from the jump that you really needed to, or it was the ideal for you to get into a program where there's already a PGY2 in place where you could early commit
Mhm.
while you're in, if the first year is going well. Are there any PGY ones that just offer specific training for mental health, or is that typically like general PGY1 and then you specialize 9 times out of 10 PGY2?
Yeah, yeah. So when I was going through the match, there was at least one program. It was a VA program in Wisconsin, I believe, that had like a PGY1 with a specialty focus in mental health. And I'm not sure if they still have that type of program or not, but at least back in 2019, that type of program existed. And honestly, like I didn't apply for that program, and the reason being is because I was like, well, I want the general training first. Like I want to be able to take care of a patient more broadly before I specialize, especially, and I'm glad I did that now because once you're in a specialty, like it's so easy to like all that stuff, it just kind of like you lose the skills. It's just like working out. Like if you're not training the muscles, like you lose the muscle. And so I knew early on that like I wanted a program that was going to give me a diversity of experiences, challenging me a little bit, not kick me in the butt, but too bad. And so I didn't apply to that program or any other like mental health focused PGY1 programs.
I think it's really helpful to differentiate what a psychiatrist does, a psychologist, what they do, and then where do you fall into that as a clinical pharmacist and psychiatric specialty. So, could you give us some insight on where you fall into the two and how those two differentiate?
Yeah, yeah, for sure. And I think that's a really I love that you asked that question because a lot of my patients ask that as well because they don't really understand like the difference, especially in the system that I work. It's like very big on respect, right? So even if I introduce myself as Frank, my patients are going to call me Dr. Tillman, right? And so just hearing doctor, there's a lot of questions like, well, what kind of doctor are you?
Yeah,
So a psychiatrist is a physician, of course. They've gone to medical school, they've done residency, oftentimes doing fellowships. And from a practice perspective, they can do therapy, so like psychotherapy. They, of course, prescribe medications, they diagnose, and have a really good understanding of like the bodily processes, like anatomy and physiology, because they've done medical school. A psychologist doesn't have like the medical components, but they specialize in the psychotherapy. So they can, of course, provide psychotherapies. That's their bread and butter. They approach it from like the research kind of perspective. They also diagnose. And, I've heard of some psychologists being able to prescribe some meds, but the system that I work within, like they don't prescribe meds at all. And so they're really there for the therapy and the from a diagnostic perspective as well. And they also kind of like do referrals, put in referrals to various aspects of care. So it's not just like the talk therapy, like they're doing a lot, right? And then nurse practitioners, PAs, kind of practice similar to like a physician, of course. They can diagnose, they do maybe a little bit of therapy, but their training doesn't, from my understanding at least, their training isn't like very in depth in therapy. I'm just like straight out of school or if they do like postgraduate training. And then pharmacists, so I specialize in like medication. So I do what's called comprehensive medication management, meaning I can initiate new medications, titrate doses, order labs. I put in referrals for care for like therapy, for instance, since I don't do therapy as a pharmacist. So I can identify when a patient might benefit from therapy, and then I just put in a referral to one of my colleagues so they can be plugged into that type of a service.
yeah.
I also don't diagnose. And so if, I'm questioning the diagnosis or the patient is presenting with some new symptoms or some symptoms that might be potentially consistent with some other diagnosis, then I identify that, right? So you do have to be able to identify like, something's going on. And then you put in that referral to care for a psychiatrist to do an eval or a psychologist or a therapist to do the eval. And so like the kind of differentiating factor is that like I don't diagnose and I also don't do therapy. And just thinking about like the years of training that maybe a psychiatrist does compared to like what a pharmacist does, like there is a certain level of like, okay, we need to collaborate, right? Need to collaborate when it's appropriate. And so you just have to know when that's, when you need to reach out and do all those things.
I'm really excited for you to talk about what you do on a day-to-day basis, but because I know a little bit about your story about before you got to this position, I think it will be so helpful for others to understand that they're not alone when they put in a lot of work, a lot of time to get a particular job. When you're told that you go get your graduate degree, go to your first year residency, your second year residency, and then you can go into this position. That was not the case for you. And that's also not the case for a lot of people. And like, what do we do with that? Because that in a form is, I think it's still like a form of heartbreak.
Yeah.
freaking disappointment, and you feel like a little like, well, that's not what they told me when I was doing all this. What's going on? So, how did you navigate that? And it's not that your first job wasn't a good job, it just wasn't a good fit for you or what you were working towards for most of your time in pharmacy. So, can you tell us a little bit about what that role was and how you navigated that disappointment and made lemonade out of lemons, essentially?
Yeah, it was definitely lemonade out of lemons for sure. So yeah, so my first position wasn't like direct patient care. I did have some component of direct patient care. It was like 25%, which basically translated to like initially like 1 half day a week and then like 2 half days a week in patient care. But the majority of it was like peer to peer. It was like peer to peer education, basically. So I was doing a lot of promoting evidence based medicine and practices, sharing updates to guidelines. I was doing a lot of like metric population health type work. It was a very like high level position where I was speaking with like chiefs of staff and director of the hospital, and even from like a regional perspective, speaking with other leaders across the region and like national. And so, from that perspective, there was a lot of skills that were being developed that I didn't know at the time that these were even skills that like were in my pathway, right? Like I'm not into the whole leadership thing,
Yeah,
And so that part of it was dope. Yeah, I appreciated that aspect of it. The piece that I like just wasn't for me was that I just wasn't getting enough patient care, right? And part of the role was coming in and telling, providers like, hey, there's this new data, there's this new way of doing things. And sometimes being met with like, hey, like I know what I'm doing, rightfully so, right?
yeah,
Rightfully so, like, hey, I know what I'm doing, or like I don't have time for this 30-minute appointment with you to talk about this thing. I'm busy in clinic. And so there was a lot of stress from that perspective. And so y'all can check my LinkedIn and see what that position title was called. But so yeah, so like it just wasn't for me. But luckily, I had a physician colleague who was very pro pharmacy, and there was this clinic that I'm still a part of right now, treatment resistant disorders clinic. TRD is kind of like the acronym. And so this physician is like very pro pharmacy, looking for some help for her patients. And so that's where I kind of landed at for like my quote unquote 25% clinical component. So again, it was like 1 half day per week initially, and then I increased it to 2 half days. And so, at that point, leading up to that, there was never a mental health or really a clinical pharmacist in the outpatient mental health setting ever in my system. You compare that to other systems similar to mine, they've had mental health pharmacists in their clinics since like the 90s. I don't know, it's been decades that they've
wow,
had it. So my system was behind the times, and I was the first one to like even have like a half day, right? And so there was a lot of, the physician that I was working with was you're the medicine guy. Like I clip the wings, like go and do the work. But of course, like my leadership was like, well, we've never had this before. So we don't know, like, we're a little bit hesitant. We don't want anything to go wrong. And so like I had to spend time on like upskilling myself because I was in this, I'm in this like non-patient facing role for so long, and I'm trying to like upskill myself. I had to like kind of prove it to my leadership, like, hey, I can come in and I can do the work, and I can do the work effectively and improve patient outcomes, improve access to care, and do all these things safely. And then eventually, like, it was like more and more like, okay, like, give you more, we'll give you more, we'll give you more. And it eventually got to the point where just the presence of having someone in the outpatient clinic, because I was doing like e-consults and all this, all this stuff, just having someone in the outpatient clinic, there was this kind of thought of like, well, we need more time with a person of this role. And so I was like, okay, I'll help draft the the business proposal. I'll help draft a proposal that will be submitted to the team that reviews the funding request and all that stuff. And it's one of those things that like low key, I was kind of miserable in my position, but I like saw this glimmer of hope like incrementally over time. And so it's just like trying to stay steadfast, not get too beat up, still come into work with, a positive mindset, positive, smile, chipper, upbeat, etc. And just knowing like, hey, like this is going to be my position. Like this is me. I'm claiming it. And so I did eventually, the position got funded and everything, and I applied, I got the position. And so now I still have like that TRD component to my role, but now I'm also in like an outpatient mental health clinic where like I have a panel of patients that I see regularly for like various mental health conditions, PTSD, depression, bipolar, schizophrenia, the full gamut of things. So now I'm kind of like in my purpose, right? It's my season, I'm doing what I've always wanted to do.
Man, that's so inspiring. They basically through you and through how you were showing up, they were kind of wondering like how they even were doing life without you. That's kind of how it sounds like it got to that for a second. Like, well, what were we doing before this? We need this to continue. And then if they wanted a full time, well, near full time position for that assistance. What I've learned from your story is if you don't know what the next step is, you use your network and you reach out. And that's even how you got your first role. It was COVID and it was looking rough in the career streets and you didn't just do nothing. You took what was available and you found a way to still grow. You were continuously making opportunities out of that and using your networks. And I think that's so important for people because we can get into roles and we can just get into this feeling of disappointment that we just give up and what was me? And then we just either remain there or we just feel like we're not having any purpose and we just accept that for ourselves. So thank you. I hope somebody's watching where they're feeling inspired to do something about it, not just accept it.
Yeah, closed mouths don't get fed. And what I'll add to that, and of course you of course know this, but during my PGY2 year, I had a kid. My wife and I had a kid. So we
That's
were,
right.
yep, it's COVID. Geographically restricted all of our families in North Carolina, and like who is gonna travel across state lines with a newborn during something like COVID, right?
Wow.
Like there was no like direct psychiatry jobs in North Carolina. It just wasn't happening. And so I was just sitting back one day and I was like, you know what? Like I had this amazing internship down the street. I'm gonna just send them an email and just see what happens. Like I wasn't even like looking on their job postings. I don't even think they had the position posted. It was like perfect timing. And I know we talked about this before, how God like lines things up and it's just like consistent personally for me. But they hadn't even posted the position and I emailed them and they was like, well, actually, like we've got this thing coming through. So be on the lookout. It should be posted in like 2 or 3 weeks. You apply, go ahead and send me your CV. So I sent my CV, and in the moment, I won't say that I felt like very reassured. I was just like kind of doing this thing kind of begrudgingly. I was like, well, I've done like a rigorous PGY1 or rigorous PGY2 with half of the year with a kid not sleeping on top of PGY2. Like I deserve a position that meets the rigor of my training and is direct patient care and is exactly what I want. And I shouldn't have to deviate from that at all. So I was doing this, like I wasn't happy doing it,
Mhm.
but I did it so that way I can make sure that I had, the ability to take care of home and myself and all that stuff. And in hindsight, like I wouldn't take any of it back. Honestly, I wouldn't take any piece of it back. I think all of it has been like, even with the struggles of the first position, like the connections that I've made, the skills that I've developed, being able to sit in meetings with like chiefs and all that and just not feel awkward in
Yeah.
itself, it's been a blessing in the back end. So,
God uses everything. So now let's get into what you do every day because now you are in the outpatient pharmacy role. So what does your day-to-day look like or your week to week look like for you?
yeah. So in any given day, I have like eight or so patients, 8 to like 11 patients a day. Um, these are like 30-minute appointments that I'm seeing patients, and usually no more than like one new patient a day. So like one intake is like 60 minutes. And again, it's the full spectrum of mental health. So like depression, PTSD, a ton of PTSD, anxiety disorders, insomnia, schizophrenia, bipolar, like, you name it. And I'm meeting with patients and their family members regularly, going over, their medications with them, doing all the laboratory monitoring. And then we're developing like plans together. The way that I describe it to my patients is like after, we're getting the interval assessment and it's time to like treatment plan. I'm like, all right, it's time to make the menu. And so, like, we go through the menu of options of things that can be considered interventions for them at that point. And of course, the menu of options are all things that are safe and reasonable, right? Because I'm not going to put something on there that they choose that I'm then like, oh no, we're not going to do that one.
Yeah.
But of course, like we develop the menu together and then like we figure out that plan together. So it's very much so like shared decision making between myself and the patient. Of course, there are the times where you've got the patient with like, who's a potential safety risk to themselves or to others. And so there's a lot of like suicide safety planning, risk mitigation, like talking about reducing lethal means with like firearms and excess storage of like medications to reduce their risk of overdose. So there's a lot of like crisis management involved as well, which I do, which is something that we don't learn in pharmacy school, right? It's something that you learn afterwards. And so that's kind of, like my general mental health time. And then in my treatment resistant disorders clinic. So in our treatment resistant disorders clinic, we do treatments like electroconvulsive therapy, cranial magnetic stimulation, which is like TMS. We do IV ketamine for depression. We do intranasal esketamine or Spravato for depression. And so I primarily do our IV ketamine and our Spravato treatments alongside the physicians that work within that clinic. Of course, I don't do like the TMS and the ECT. Those are well beyond my scope of practice. And so, I'm one of those providers that's, treating patients, treatment refractory patients with IV ketamine, titrating those doses, determining when the patient's going to come back for their next treatment. So, and these are the patients who are like very sick, right? Like they have gone through all of the SSRIs, all of the SNRIs, all of the, medications that you can think of and are now to us because they have such refractory illness. And then e-consults. So when you're a pharmacist, you're going to get curbsided about medications. It does not matter if you have a full clinic schedule, right? You're going to get curbsided about, uh, you know, this medication, that medication. And so I do a lot of like chart review notes, e-consult notes that I'll send recommendations to providers on. I sit on a committee where I'm a co-chair and review overdoses over the past year. It's an interdisciplinary committee, and we develop recommendations to mitigate the risk of future overdose policies. Like, so basically the role of the pharmacist is not just like medications, right? You can see that there's so much more. Like I'm doing referrals for therapy and occupational therapy because this patient keeps falling, so I need occupational therapy to come out to the house, referrals to PT. This patient has memory issues, so I'm referring for neuro testing, for instance. And so this patient like has some questionable like seizure like activity, so I'm referring to for neurology, or like their sleep apnea is uncontrolled. So I'm referring for to our CPAP clinic. So it's a lot more than just like what we learn right in pharmacy school, thinking about like the pharmacology and the mechanisms of action. Like you're learning a lot once you get past that those 4 years and even those 2 years from residency.
And were you learning this as you went on the job?
As I went on the job, yeah, just learning like what the resources even are, right? Like what is vocational rehab and what do they do? Like this patient is presenting to me with PTSD. And so there's so many different um, therapy protocols for PTSD, right? So do I refer for prolonged exposure, or do I refer for cognitive processing therapy? Or do I refer for image rehearsal therapy? This patient has significant pain. Am I thinking about acceptance and commitment therapy for, pain, or am I thinking about cognitive behavioral therapy for pain? And so, of course, these are things that I'm like needing to upskill myself on. So doing a lot of reading, but then also like very fortunate that I work within a team that is approachable, and they're like, we're having the discussions and I'm just like listening, right? I'm learning as they're having these discussions, and I'm learning like, how do I increase my ability to practice, right? And I think that's so important for pharmacists to do, right? Because especially if you're in a system like myself where you're practicing at the top of your license from a pharmacy perspective, you realize that there's other things that exist outside of like just the medications that you can also have an impact on. Knowing how to stay within your scope, of course, that's
Yeah.
important, right? Make sure that you stay within your scope. But there's so much that you have to continue to learn, and you have to like stretch those muscles.
I didn't understand what any of those therapies were except cognitive behavioral therapy. I just want to put that on record. So I
Hey,
didn't even know all those.
just know that they
Shit.
exist.
Oh my goodness. So you have to understand the different mental illnesses and how they're diagnosed, how they show up as. You're also needing to know all the medication options, their side effects, the things you have to adjust based on organ function. Do you also need to know the differences between ages, like depending on the age that you're treating or the gender that you're treating? Do those things take into account how you're going about your menu when you're putting together your menu?
Yeah, yeah, for sure. So, a lot of my patients are elderly, and if they're not elderly by age, like physiologically, like they're a little bit older, right? They just present as older. And so a lot of the decisions that I'm making are in that context, right? Like, and this goes back to that art, right? Of like, what's the receptor binding of this medication? And, what's the anticholinergic burden of their regimen? That kind of thing. Like, will it impact their, their memory or contribute to delirium or falls, or will it dry them up and they're not urinating and that type of thing? And so that definitely comes up a lot with the elderly patients. And then, sometimes with the younger patients, just thinking about, okay, like this thing, the chart says unipolar depression, but, they're, maybe like irritable and like maybe they're having some issues with impulse control and they're not getting good sleep, but they like have this like really super high energy. And I'm like, oh, is this like potentially bipolar disorder, right? And like, do I need to be a little bit more like selective and careful with the medications that I'm considering for this patient? And then that also goes into the fact that like I don't diagnose these patients, right?
Yeah.
And so, like, is this appropriate time for me to reach out to a colleague who does do that type of work? So that's how age comes into play. I work in a system where I don't have a ton of like young women who are like pregnant and lactating. And most of the women that I treat are a little bit older, but in those rare circumstances where we do have the younger women who are pregnant and lactating, that definitely comes into play. And because we don't see those patients often, it's always almost immediately like we're going to reach out to our PharmDs. Since I don't see it often as well, like that's something that I have to, I have like I basically have like all the things stored so I can just like pull back from it, work efficient. And then I would say, the last thing that comes into mind is, so I work with like military vets and just really understanding like the era of, Vietnam, Korean War, Iraq, Afghanistan, like the stressors and like kind of the way that they present is a little bit different.
Mm.
And so that's one thing that comes to mind.
Differently, each war that they were in is a little different.
Yeah, yeah. So like for instance, like Vietnam era vets, the common thread that I get from them is, there was a draft, right? So many of them didn't volunteer to be in the war. So they were drafted. And then there was a lot of pushback socially about our involvement in the Vietnam War. And then when they came back, they were there in face of combat, right? So seeing a lot of traumatic things, near death experiences, right? But then when they come back, they're not treated as heroes because there was, again, opposition to us being there. So they were called like baby killers and like spat at and so like just that dynamic of fighting for your country and not really having a choice for many of them, for some of them, and then coming back and not, having like trauma on both ends. And so that kind of presents a little bit differently than maybe that veteran who volunteered to go into the military and went to combat. And not to say that they still experience the trauma, right? But it's like a little bit different.
Yeah.
And it's not to say that it necessarily impacts, in some cases it can impact your treatment plan, but it's just kind of like the sense of empathy, right, that you have with the patient, like just understanding that person's background is really important. We think about, it's so funny, we think about like race and ethnicity and gender identity and all these things, and those are important, but it's also kind of like, like what was your childhood like? We get into that kind of stuff, like, what was your childhood like? You know, your marriage, like that kind of thing. So it's like so many different aspects of one's life that they're coming to you with in that appointment, and you're hoping to kind of understand those various elements that can one build trust, build that therapeutic alliance, make that patient feel better. And the 30 minutes that they come in with you, so they're leaving feeling better, feeling maybe a little bit more confident, even if it's just those 30 minutes. and then also directing like patient, care plans as well, because some of that stuff can come up.
Wow, that is so insightful. I would have never even considered that. I'm not in that field at all, but that is just so insightful. Thank you for sharing that. And then that also makes me wonder, because you work in the mental health field and you are hearing so many stories of people's upbringing in their past that have contributed to their trauma or mental illnesses, and also or just birth defects, or whatever it might have happened. There's a lot of offloading that's happening in this room with you. How are you managing all of this? How do you, or do you, have you been able to find a way to shut it off?
Yeah. So honestly, I feel like if you talk to like 10 different people that work within mental health, 10 different roles, you'll get like 10 different answers, honestly. I'm an emotional person. I'm an emotional person at baseline. I feel empathy, towards people and situations. I'm that person that's crying at the wedding, right? And I have to just own that. And so, of course, you have to kind of try to turn that off in the appointment. And so when I first started, even like in residency, like just being, a resident, and that was mostly like inpatient, like it was kind of like hard on like, okay, doing the internal, like, all right, like you got to turn it down, just kind of feeling so emotional about the stories that are being shared and they're so vulnerable. Over time, I've honestly learned to compartmentalize. And the way that I've personally learned to compartmentalize is to kind of think about the patient and their conditions and what they're presenting with, similar to how we would with any other medical condition. So like diabetes or like heart failure. You think about like all of these risk factors that might have contributed right to their diabetes or their heart failure or whatever. And I've kind of like, I don't know, trained my mind to think about like, these traumatic things or like risk factors that led to like what they're experiencing now. And in my mind, at least in the moment, it allows me to kind of like just reframe from feeling like sorry for them, not to say that I'm like lacking that empathy for them, but it allows me to kind of like just reframe my focus and think about, okay, like let's think about treating you and getting you better and optimizing your outcomes, and these things that have happened in the past influence how we do things today, but we're going to focus on like how do we influence things today, right? And so yeah, I try to after work, like I try to like I use my car rides. I have like a 30-minute drive. I use my car rides to talk with family so I can time
Yeah,
it. All right, we got 30 minutes. That means I can talk to you for 30 minutes, and when I get here, like we're off the phone.
yeah,
That allows me to just decompress for the day. So yeah.
yeah,
But it can be hard sometimes. I mean, I find myself like thinking about that patient who might be in crisis and maybe staying up, like not sleeping sometimes. It's gotten a lot better over the time. But when that does happen, I just tell myself like, hey, that's just compassion. That's just compassion for the patients. So
yeah,
yeah.
yeah. I'm also a big empath.
Yeah.
Things will transfer to me whether I like it or not, and I will have to have an intentional, like, sometimes I feel like a robot. Like I'll just have to like make a decision to
Make a decision.
switch it
Yeah.
up. I have to make a decision to block it out, and if I don't, I just carry it, and it can feel so heavy. So it's 2025. There has been a lot of progression when it comes to how we perceive mental illnesses. I think we have come a long way, but I'm not in this space like you are. So, what have you observed? How is mental health? Is it still being addressed and stigmatized? Do people still feel a level of shame when it comes to receiving a diagnosis, or even being a little resistant or in denial when they receive a diagnosis? And how are you navigating that as someone who's trying to now put them on therapy that can help them or protect them or others? What's your experience with that, and how do you navigate it?
Yeah. Yeah. I mean, so stigma is definitely still a thing for sure. I think there's like varying degrees of stigma, right? You've got like just the overall, like just community stigma, like the work that we all kind of like experience and see, and it shows up in like movies, and it shows up in kind of pop culture and various facets. What I will say is that I think the this newest generation, Gen Z, I think they're doing a good job of kind of shifting that a little bit, and so I'm excited to see just what that looks like in the future. And then, of course, you've got the stigma that comes up with the patient, and one of the biggest kind of things that I get from patients is like not wanting to be weak, right? Like not wanting to be perceived as weak or unable to you know do the things that they were once able to do. And of course, a lot of these mental health conditions can impact the things that you were once able to do or that you once wanted to do, right? And there's also kind of like stigma around like substance use as well. That's another kind of population that I work with, and so I see a lot of stigma there. I see that show up in various ways, not necessarily like within my system, but just broadly. So of course the stigma with like patients, like kind of like the guilt and the shame and so forth. But then even kind of like that therapeutic type of pessimism, like, oh, like the patient's using alcohol, there's no way that they're going to be able to improve on XYZ aspect of their healthcare. The patient is using this substance, that substance. No way that, they're going to be able to like, improve. We're not going to be able to improve anything. We'll hold back this, hold back that type of therapeutic type of reaction. Um, and so, the fortunate thing is that most of the patients, by the time they've gotten to me, like they've gotten a diagnosis, right? All of them have gotten a diagnosis, and many of them have been in treatment for many years, right? So like I'm not the first person that they're seeing, and so in my current role, I don't get a ton of that. Like, hey, like I mean, I do get it, but I don't get a ton of it. Like, I don't agree with this diagnosis. I don't think it's real. I don't think it's accurate, or so forth. Now, what I will say is, although many of my patients will acknowledge their mental health conditions, there are some times where it's like, hey, like we should probably think about therapy, or we should probably think about this. And that is where I see a bit of like a rift sometimes. Like therapy ain't gonna work. It ain't gonna help to talk about things with
Mhm.
anybody. And I think there's like a big miscommunication or misunderstanding maybe of like what therapy is and like what it looks like. I think a lot of people think of the classic like sitting on the couch and seeing like the images and being like, what does this image look like? And speaking to a quote unquote shrink. And that's just not the nature of what therapy is. Um, so yeah, I mean, I do I see stigma come up in different ways, and oftentimes like it's something that we just kind of like have to chip away with over time, and it comes with like trust. The patient trusting us, having that bilateral sense of trust, gaining that therapeutic alliance, and just not pushing them too hard until they're ready to make the decision themselves.
Talk to our folks who are considering mental health as an option for them. You said that you mentioned it, inpatient clinical pharmacist and outpatient clinical pharmacist. Can you break down the two for people who aren't familiar with those terms? And then can you also provide other areas that pharmacists can get into with mental health?
Yeah, for sure. So there's even like some more like subcategories when you think about like outpatient and inpatient too. So like inpatient, you can be like on a psych unit, right? Like a locked unit for patients with like acute psychiatric conditions. You can be on like memory units for like dementia, for instance, long-term facilities. So there's got like substance use facilities where patients are kind of there and they're staying and they're getting substance use treatment, for instance. So those are like all different types of like inpatient settings where you can work in as a pharmacist.
That's hospital, and then that's also like assisted living, long-term care.
Yep,
Okay.
yep. So you've got like assisted living, long-term care, and then you've also got like rehabilitation
Ah,
programs
awesome.
as well. Yep. And so those are like where the patient is admitted there for, X amount of weeks getting like some type of treatment around substance use, for instance. And so you're there in like a domiciliary type of setting as the pharmacist. And that's considered kind of like an inpatient role. And then outpatient, of course, you got your general mental health where you're doing like the bread and butter things like depression, etc. You've got substance use disorders clinics. There are some mental health pharmacists that are embedded within like primary care clinics. where they're providing like mental health services within a primary care clinic. You've got like the clinics, the teams that are going out to people's homes, like the assertive community teams or like the ACT teams that some people have probably heard about, like the high intensity case management types of teams where patients have conditions like schizophrenia or like bipolar disorder, like, severe conditions, and they need that like in-home intensive case management. And so you've got pharmacists embedded within some of those teams as well. You've got some pharmacists who do like telehealth services. So they're like popping in for different facilities to help out with gaps and access to care. You've got some pharmacists who are doing outpatient work, doing like rural health and some of like the rural, harder to reach areas for patients. And so it's so funny. One of my colleagues was telling me that one of her patients in rural health like lives on a boat. And so she's like, you just got to think about like, how do you make interventions for somebody who lives on a boat?
What?
And so there's a lot of, so it, never a dull moment. Right. And so, I think that's a pretty good comprehensive type of list of like, you know, um, clinical jobs within like the healthcare setting for mental health pharmacists, but you've also got like programmatic type of jobs where maybe you're doing like harm reduction work, right? So you're thinking about like sterile syringes and access to sterile syringes and naloxone and overdose education and outreach and population health. So, there's like those types of roles as well. And then of course you've got like all the others like the academia, the industry, the um, all of the things outside of healthcare. These are also healthcare positions, but outside of direct patient care, I should say, a mental health pharmacist can get into as well. So it's a lot of options.
Yeah, I didn't know there were so many options. Do most of these positions require the extensive training, the PGY1, PGY2?
I would say like your chances, your likelihood of securing a position quicker, faster is probably higher with a PGY1 and a PGY2. Reason being is because it's just so competitive, right? Like you've got more and more pharmacy schools that are being developed, being created. So we're pushing out more pharmacist graduates each year. And the competition is stiff. And so like just standing out is, PGY1, PGY2, that's one way to stand out. But it's not to say that you can't make your way into one of these roles. I know several people who have made their way in these roles, not even just mental health, but like just different facets of pharmacy without any type of postgraduate training. But you got to have some finesse to you. Like you really got to have the
Right.
connections and know how to reach out and know how to stand out when you're showing up in places and put yourself out there if you haven't done the training. And if you're an introvert like me, that's hard.
And on top of that, you have to have the ability to network and connect with people, but you also need to have the ability to go home after work and be in the books and studying.
Yes, that's an important part.
Do they have a certification in mental health?
Yeah, yeah. So they've got it's called BCPP. So it's board certified psychiatric pharmacist. So that's kind of one of my certifications. And then I've also got BCPS, which is board certified pharmacotherapy specialist.
Yeah,
Yep.
that's the one that I have.
Okay,
Why did you
BCPS.
why did you
Yeah, it goes back to that whole like imposter syndrome thing, feeling like you need a little bit more to stand out. But no, I got my BCPS after my PGY1 year, and like all of the other residents were doing it, and I was just like, okay, well, I guess I won't be able to sit for the board certified psychiatric exam until after I'm like getting a job in mental health. So I need to have some type of like, oh, I got to have some type of board certification when I'm applying to jobs. Because otherwise, if I'm just PharmD, I'm not going to get picked up because I don't have a board certification. So I got the BCPS, and it's definitely going to get dropped once it expires.
that's
Also
so
not
good.
paying for that ongoing after 2027.
Yeah, you've made it.
Yeah, yeah, I'm
Yeah.
dropping it.
That is hilarious. It's so crazy that you said I'm not gonna get a job with just a PharmD.
I know, right?
That's
The
a
way
whole doctorate degree.
I know the way our minds like trick us into thinking that we're just not.
But it's not our minds. It is how the market is right now.
Yeah, true.
I got a certification because I wanted to be competitive. I was already in my first job when I was about a year and a half into my first job, and I decided to get certified.
Yeah,
But
it's got
I did a PGY1 because I'm general. I don't specialize. So I was like, this is good for me. Over and out. I got what I needed.
Hey, but you in there, you in there. But yeah, I
Yeah.
mean, it is stiff. Like it's hard, and there's a lot of. I mean, there's any position you apply to is probably going to be like, you're competing against so many applicants, maybe people who have more experience. So yeah, you got to differentiate yourself in some type of way. There's this like push even after you finish residency to like, okay, like I got to like do some research, I got to publish. And I can understand why some people do feel that way. I do research and I publish because I enjoy it, right? And I haven't that aspect of my work hasn't burnt me out quite yet, but I do know some of those people that are just like, okay, I gotta publish. I gotta like, do these talks and do this and do that, and do this research. And so in one sense, I mean, it makes me feel like, okay, like I am practicing, I am in healthcare and I should be contributing to new knowledge, like why not contribute to new knowledge? I think that's where I'm at right now. But it is sad that there's like that's almost kind of like expected. And if you don't have the capacity, if you don't have the desire, the interest, like you're kind of like SOL in a
Yeah.
sense. So,
Because what about the people that just want to go to work and go home?
and that should be an expectation that should be like acceptable.
It should. It should be enough. So how are you incorporating research into everything that you have going on? Like where does that come into play? When and how does that get done?
Yeah, so through residence. So I mean, honestly, like I wouldn't have the time within my day to like do data collection and like do all that stuff. And so I have like PGY1 and PGY2 residents, and I essentially like would develop a protocol or like a research question, and I'm just kind of like mentoring the resident throughout their research. So they're doing the data collection, and I'm the subject matter expert or like the primary investigator, kind of like driving the research along the way, which is nice, right? Because I think it's mutually beneficial, right? They're learning how to do research and I'm learning how to coach them through it and also like addressing this clinical question that I have. And so that does add on to the day. That's one of the extra things throughout that week that you kind of like we talked about earlier
Uh-huh.
that does come up. Just kind of working with those residents.
And with that being said, what is some like overarching advice that you can give to people who are looking to get into mental health? I'm really looking for like mental resiliency points.
Yeah, yeah. So I'll try to break down this because I think there's like several kind of components. I think one is the very first thing is just like knowing yourself, right? So like, how do we pursue something when we don't really know ourselves? We don't know what we want, right? Like we see this outcome, we see this thing in the future, we see this endpoint, but we don't have a good sense of ourselves, right? And so like how do you get to an endpoint when you don't know the strategies, the methods to get there? You don't know if you want to get there. You're just like have this vision on things, right? On
Mhm.
something. And so I think the first thing is like just kind of doing that inner reflection and knowing like is my endpoint truly the endpoint that I want to get at, right? Because how bad would it suck for you to do all the things, jump over all the hurdles, and then you get there and you realize, dang, like I never wanted to be here anyways, That
Mhm.
would be terrible. So I would say like that's the kind of like first thing is like just really knowing yourself. And if you have to do that by journaling, if you have to do that by talking to mentors, that was the thing for me was mentors, like really getting a good understanding of like all the different options and like just really using them as like my village, my support system. If it's going to therapy, whatever it is, whatever your method is, try to figure out like, okay, who am I? What do I want? And does my endpoint align with my passions, my vision, my personal mission in life, etc. And then I think, from there is like, create a plan, right? Like create a plan, shoot for the stars. The program that I mentioned earlier when I was in high school, we always had this thing that we had to say, and it was, if excellence is possible, then good is not enough, right? And during the time, I thought it was really harsh. I was like, dang, like good is not enough. But I would always say it. And in hindsight, what I realized is that I wasn't saying it to them. I was saying it to myself, right? Like I'm not saying it to the program directors of this program. I'm telling myself, if excellence is possible, then good is not enough. And so I say that to say, like create that plan and shoot for the stars. So that way, if you do fall back a little bit, you're still on a level of comfort where you're satisfied with what you've got, right? And I think with that, if you have to deviate from that plan, it's okay to be upset. I promise you, it's okay to be upset. It's okay to be frustrated. It's okay to feel unease, but do not give up, because when you give up, you are sowing the seed for failure at that point. Once you give up, if you continue to work and push and try to figure out ways to pivot around the hurdles, you're more likely to end up at that point, that end point that aligns with your vision, with your passions, etc. And then I would say, in terms of like tangible things to reel in, is like, one, like, it's very clear, like, you have to do the work, you have to know the things, you have to do the studying, the learning, all of those things. But I think it's also important to make meaningful connections over time. It's very rare that like you can end up at that point without like making any connections, right? You've got to make the connections. They don't have to be forced connections, but just identifying like who am I, and like who are the people that I want to make the connections with, because those connections can end up in a way that they can lead you somewhere that where you might not envision yourself, being. And that happened for me, and I think it can happen for other people. So, yeah, thank you.
That was so good.
Thank you.
Thank you so much. Is there anything that you would like to share additionally, before we close?
Yeah, absolutely. I do. I want to say that what you're doing with this podcast is amazing. It's dope. I know that I like reached out to you on LinkedIn and like messaged you, and I'm like, yo, Tom, like, you're doing great. Like, I've been watching your podcast and I've been really impressed. But I do want to like share that publicly. I want to share that publicly. Like, you're doing an amazing job. You've got people, myself included, who are like looking at these podcasts, who are learning from it. Um, and so just keep doing the work. As I'm just glad to see you in your season doing your thing, and I hope you continue to be in your season doing your thing.
I appreciate it. This is a lot of extra work, outside of a 9 to 5, but like you said, it makes me so happy. It's so fulfilling. And at the end of the day, for some reason, when it comes to us helping other people, we can find the energy, we can find the motivation a little bit more than we can do for ourselves.
Oh yeah,
But yeah, this is really me also finding my happy and knowing that I'm doing something above and beyond that also pours into the next generation of people, and also people, pharmacists who are practicing that aren't happy, because that's real life, right? So thank you. I appreciate it. I
yeah, yeah.
appreciate it.
Thank you for having me.
All right, everybody. We hope that you learned so much today. And I feel like Dr. Tillman let y'all know that y'all can go to his LinkedIn, check him
All right.
out, and see what he's been up to and what he's doing. Do you have your papers published on LinkedIn?
No, I don't. I don't. Yeah, I'm not that fancy on LinkedIn.
All right, I'm sure they can find you.
Yeah, they can find me on LinkedIn. They got PubMed. They can go to PubMed.
All right. Well, thank you everybody for joining. Stay blessed and stay curious. We are out.